and I'm a paediatric PEM consultant from the Northeast. I lead on the paediatric side of POCUS locally, and have been using POCUS for around about 5 years now, and would like to welcome to our first session. Just, can everybody see the slide moving along? Hopefully, yes.
Yep.
Wonderful. So yeah, this is our first PEM POCUS UK session. So the idea behind this is that it could be a platform basically for a monthly or potentially more frequently get together to help educate each other, share cases. It could form a type of supervision for more junior people who are scanning to get a bit of feedback from more experienced people in the group. If any trainees would like to look at a small topic, so undertake a literature review, I think that'd be a really great thing to do. And within the paediatric POCUS literature, there isn't a huge amount, so it wouldn't be a massive task to do. But then one thing I thought about formulating a group like this for those who are undertaking a lot of scanning in their own departments up and down the UK is that we could maybe collaborate on projects and things like that. And I've got a few ideas in mind that we've already begun to do. If there are any branding experts on the call, I would need your help for a nice catchy acronym for PEM POCUS UK. So the idea for this came about basically with two groups that I'm involved in over in North America. We meet on a Wednesday and a Thursday respectively, and I've been part of this for around about 3 years. And it's all PEM based, and it's an excellent thing to do, really. It lasts around about an hour, similar to what we'll aim for today. And it's mainly in the form of cases, and because it's all people who are fairly experienced with scanning, it forms a kind of a, there's a lot of kind of professional discussion going on about different appearances on scan and really unusual cases. So I'll be happy to share the details of that as well. But wonderfully, we've got our own group now for the UK, which is excellent. My logo is on the left. I'm definitely no graphic designer, but the one on the right was attempted by my 8-year-old son. And I mean, all I can say is that given the events up and down the UK over the last couple of months, probably the less said about that, the better. I don't know if he's implying that we should be probing into the royal family or what, but yeah, so we'll stick with my effort for now unless anyone has a better one. So these are all of the things that I would scan for in my department. Me and a few colleagues have been scanning for, as I say, around about 5 years now, and that's began to cascade down to other members of staff through our courses, which is under the badge of SUNUS. And just a tiny bit about our background, because I often get asked about this when I do talks. So in essence, when I came into post as a consultant 4 years ago, I was in the position where a lot of newish consultants across the emergency medicine side and acute medical side were all interested in point of care ultrasound. And it really just took it kind of exploded from there, and the momentum kind of continued, whereby we formed our own group, SUNUS, and yeah, we now host our own courses locally. So what I'd like to do is, for today's discussion, is to talk about a really common problem, which is the limping child, which I'm sure all across emergency medicine and paediatric emergency medicine we face really commonly. So around about 4 years ago, I scanned my first ever child's hip. And the background was that this was a 1-year-old boy who presented into the department on a weekend. He appeared okay. It was a very standard story, I'm sure, for all of us in PEM and EM, of having some history of temperatures, but was afebrile when he came in. He'd had a bit of a cough and a bit of a runny nose, and he'd been up on his feet, sort of starting to cruise over the last couple of months. And when the junior doctor reviewed him, this is how he looked, which is a really common sight, I know. And just as he'd been observed and was about to be discharged, his mother said something quite interesting. She said that he seemed to be holding his right leg or his right knee. And sure enough, when the doctor went back in to review him, he wouldn't put down his right leg. So he was reviewed by one of the registrars, and she was a bit puzzled, and she undertook this legogram, which I'm sure you'd imagine for this sort of story, spontaneous onset of not weight bearing, was probably not massively helpful. So I then was asked to have a little look at him when I arrived for my shift in the afternoon. And I just undertook training for scanning hips and for looking for things like joints. And this is what I found. Hopefully the cine loops are all visible there. So when I looked on the side of concern, I could appreciate that the appearances were really quite different. And we're going to get into exactly what these appearances mean. So I was in an interesting position here because this was genuinely the first ever hip that I'd scanned, and I almost had acquired more information than I would normally have. So we had, in summary, a 1-year-old child who was well, but who'd had a history potentially of temperatures at home, who had stopped using the right leg very, very suddenly. So I discussed this with the orthopedic registrar, and we together came up with a bit of a plan that there were certainly features that we would consider red flags so that this child will warrant some bloods. And as you can see from on the screen there, we undertook the blood tests, attempted to get an ESR, but I mean, has the lab ever processed anybody's ESR sample ever? I don't know. But we did get a CRP back, and it was massively elevated, much, much higher than what I was anticipating. And again, I'm sure we've all been in these positions whereby we've had a test result or some form of information that can almost hinder our decision-making process, given that this child looks so well. But we decided to admit and observe the child. And in essence, the child had remained afebrile, but sure enough, the orthopedic team reviewed him and felt that this child, given his history and given his inflammatory markers, would be consistent with septic arthritis. And he was. So he went to theatre and grew pneumococcus from the hip and completed some IV antibiotics and did fine. So that was, I can assure you, that was the first ever hip that I scanned. And it really opened my eyes to what potentially might be out there. Now, we know obviously septic arthritis is far less common than that. We've looked at the data as part of one of our studies, and we get between 0 and 2 cases a year maximum of the hip, septic arthritis of the hip. But again, it really opened my eyes that the point of care ultrasound would be a really, really useful tool to integrate into my clinical practice and help us make better decisions. And we've continued on from there, really. So a little bit more about the how-to. I mean, I think for those of you on the call who do a bit of scanning, this might be a kind of entry-level talk, but I think it's a really nice place for us to start. Going forward, we can see what the lay of the land is with the group, but it might be that we can just get straight into various cases like we do with the other groups I'm part of. And again, they might be much more puzzling and much more confusing. But this initial talk, is a bit more of a how-to in terms of hip scanning and how we use it. So this is the machine that we have in our department, the GE Logic, which is a really excellent machine for musculoskeletal scanning. It's not as user-friendly as some of the touchscreen ones, but it's brilliant in terms of the pictures that we get. And we would use the high-frequency probe when we're looking into joints and for skin and soft tissues. It's the same probe we'd use for IV access for those of you that have done scanning before. And with that, we get an excellent degree of resolution, but we compromise a little bit on the depth. Because of that, we don't need to see much greater than sort of 4 centimeters maximum. So the technique that we teach it at the very start is that you'd align yourself along the femur with the probe. Really now, ultimately, I'm just placing the probe in the kind of crease, the obliquity of the crease, as shown in the second image there, to identify all of the structures of the upper hip, which we'll come on to. If anybody does have any questions as we go, please just jump straight in. That's not a problem. I'm trying to keep an eye on the chat, so I'll be more than happy to answer things as we go. So this is what we call a sonographic anatomy. This is what we see based on the appearances, how to do the scan on the left. This is what we would see on the right. So we'd see the muscular layers, and in this case, the iliopsoas. And directly beneath that, we'd see the sort of cartilaginous capsule structures of the hip. And we know in children of different ages, we're going to be seeing various kind of bones of different stages of development. But the common one we'd see for children who we scan for limp, because obviously it's a common age group in preschool and school age children, is an unfused epiphysis. So we'd see a femoral head at the end, and then we'd see the remaining part of the kind of articulation of the femoral neck below that. Just a quick one about the scanning plane, not to try to kind of confuse anybody, but we're looking from anterior to posterior from above, aren't we? Scanning in that blue area, which is what we call the anterior recess, and just shown in this infant there. And then essentially, when the image is flipped, you're looking downwards. So you're not kind of scanning the lateral aspect of the femoral neck, which is almost what I thought it was when I first started doing it. We're looking down from anterior to posterior, looking at that shallow fossa that we can show there from the blue box. And then POCUS is really excellent when you start doing all the MSK stuff, because it really reminds you that you're maybe not as good at anatomy as you thought you were, and you have to remind yourself exactly where everything attaches and exactly the remits of all of the different joint spaces. But in essence, there is a synovial region, and there is a kind of a circumferential capsule going all the way around. And in joint effusion, that's the area that becomes filled with excess fluid, or pus in the case of a septic arthritis. And it's just important to know that there's some aspects sort of more superior that will always look dark on ultrasound, because that's part of the normal kind of capsule, but we'll come on to that in the next few slides. Any questions at all so far from anyone? Okay,
Dave, there was just a quick question. Was the kid you're talking about holding the knee or hip?
Well, so this is exactly why I described it in that way. So the child, when I came in, was stood on one leg on his mother's knee, and we were always told that it's the hip, aren't we? We're always told that. Sorry, pardon me. We can always be told that it's the knee or the foot or the leg. And I think the key bit about this child is that he'd literally just stopped weight bearing almost within that 1 to 2 hours of having him observed to see whether he did have any temperatures in the department. He literally came in and had stopped weight bearing. So I think in this case that the registrar might have thought, was there a subtle trauma that had gone on within the room while he was there, hence the x-rays. But yes, she'd said the knee, but we know on balance that so much of this pathology can be distilled down towards the hip, can't it? So this is a more high frequency.
Excuse me, Dave, are you displaying slides? We're not seeing any slides. Are you actually showing slides?
Oh yes,
slides.
I can see slides.
That's good. I would start again.
We can
So
see.
thank you for the thumbs. That's good, actually. When so many on the call, that's reassuring to know. So can anybody other than who just spoke not see slides? It's unusual, isn't it? Okay, so I can see slides. Okay, great. So does that mean the person who joined has seen nothing so far? And I'm just trying to understand why that might be. Various different links to the meetings, perhaps. I don't know. I'm really sorry if you can't. Did you want to try and leave and rejoin, perhaps? Because that might be that'll be a really hard talk to follow without seeing any of the stuff that I'm talking about. And I'll keep an eye on the chat. Right, sorry, I've got the chat open.
Yeah, just that.
Okay, so people are going to try and rejoin. And then I've got a question from a colleague in our department in relation to differentiation between pus and serous fluid. Excellent question, Amna. So we're going to come on to talk about how we integrate POCUS for hips into clinical decision making. But in essence, I think you're armed with a few kind of rules in your mind. One is that obviously a child with a septic hip, one is far, far less common than what we see for transient synovitis. So I always just think that's worth bearing in mind. And also that their clinical presentation is quite different often. But in terms of the evidence that's out there, this was one of the first things that I wanted to look into, looking at it in quite a bit of detail in terms of using things like power Doppler and all sorts of subtle things. It is that clearly when we see fluid within a joint space, we see a very anechoic, uniform looking fluid like what's on the screen for those who can see it. And ultimately, fluid on ultrasound is black, isn't it? It's dark because the way the molecular structure of fluids are is that there's minimal reflection back to the ultrasound probe and really rapid transmission through that fluid away from the probe. So that normally looks very black and very what we call uniform. But when the septic joints that I've seen, and I've seen maybe 3 or 4, tend to look over time slightly more complex. So there's kind of almost kind of hyperechoic bright striations within the fluid. There's an organization quality to it, and it looks very similar to that of like an empyema within the chest. But if you were to look at your average child and say, can we differentiate at the outset straight from looking, then I think the answer based on the current evidence is no. So this would be an excellent area to look into as part of kind of ongoing multi-center stuff between us, but there's really little evidence about that. And then the last question there is, would you get an effusion for transient synovitis? Absolutely you would. So that's basically what I'm going to be coming on to talk to you guys about now. But hopefully that's all clear so far from what I've said. So just in terms of looking at any fluid, first of all, before we try to get into the kind of clinical assessment and clinical decision making, we're really looking in this region for the appearances of the capsule. Now, the capsule can look a certain way. It can have the dark fluid in, which is really obvious to appreciate on this image. And there are cutoffs for what's normal and what's considered to be beyond the normal range. But I can assure you guys, for anyone who starts to do this, it's incredibly binary to do it. It is incredibly yes, no. You know, I show it to a fellow or a trainee on the first ever time they see it. And it's the kind of one they're quite wowed by because it's such an easy decision to make. I almost look at the thumbnails on the bottom of the ultrasound machine before we blow the big picture up, and you can appreciate it really well and show it to parents who, again, really like to see the difference between abnormal and normal, what we're describing to them. But another really subtle thing to look at is to look at the shape of the capsule. Can everybody see my mouse where I'm moving it to?
Yes.
Thank you. It's great. So we're looking at this capsule, which looks like, you know, a fibrous material. It looks slightly more hyperechoic than the spaces and the fluid, similar to bone, really. And in effusion, it has a convex appearance to it, rather than being concave and dipping down here. So even if we see this tiny, tiny little rim there, you know, you can begin to look and think, okay, is there any fluid within that? Is that normal? And there are cutoffs, of which a few of my colleagues from the American groups, one of them wrote a paper looking at this cutoff of 2 millimeters. And I think that's a fairly reasonable place to start. But equally, we can begin to see the big differences when it's from unaffected to affected. Of course, there might be bilateral changes and you might just need to measure them specifically and keep an eye, but it's such a binary appearance. So I wouldn't be worried too much about how it's going to look when you're scanning. The likelihood is you'll recognize normal and you'll begin to recognize abnormal. And then somebody's asked about, should we correlate with inflammatory markers? In this case, CRP was raised. Definitely. So this is what we're going to get onto. So obviously in my case, the child had septic arthritis, and the way we integrated that, lots of questions. The way we integrated that is that's the crux of this talk, really, what I'm going to be talking to you about. Where is the point of measurement? I'm so glad everyone's dead keen. That is the next slide. So hopefully that answers your question. So there are different ways to do this in the literature. Effectively, a good starting point is from the bony cortex at the bottom, which is where the arrow starts, where the line starts here. Occasionally, it's known that you could measure from the bony cortex to the, the anterior part of the capsule just here. Others are looking at the edge of the capsule. I think both are in the literature, and it doesn't really matter either way how you do it. The key thing is that one, you're comparing abnormal with normal. Two, you're going to be measuring from the same place every time. So you're going to be keeping an eye on, at a child at follow-up. You're going to say, has this effusion reduced? Of which, of course, it always does. It often halves or clearly completely disappears. So again, I wouldn't be too hung up on that. This is just different types of convention. And then there's just another overview, kind of diagrammatically, of how the capsule can look convex. So in terms of a little bit of evidence in the background, we know that ultrasound is the gold standard for looking for effusion, and that X-ray signs are very rarely present. That you do hear a radiologist talk about a little stripe, kind of gluteal stripe, implying effusion is something I notice quite often. But there was this excellent paper conducted by Vieira and Levi, who basically taught some nurse practitioners to look for effusion with just a small amount of focus training, and would they be able to kind of identify that effectively? And you can see from the study data there that it performed really, really well in terms of being able to differentiate. Oh, thanks. So the person who couldn't see the slides now can. That's great. There was another study in an orthopedic journal which looked at really kind of how reliable this was. And I think there's only one thing that I've noted, which is part of a piece of work we're doing, which I'm going to come on to talk to you guys about, which is about the possibility of ultrasounding very early. So it's not that common that a child would present this early in the process. I would say on average, looking at 5 years worth of data we've got, it's probably around about kind of 12 hours, 12 to 24 hours is the average period of time a child presents. But I have occasionally seen children present within, 4 hours of limp and pain. And this paper suggested that scanning below 24 hours can have a false negative effusion. Now, it seems reasonable if you've got a child who's limping that you're going to instigate some degree of follow-up there, particularly if you haven't seen what you felt you might. So I think that doesn't worry me too much at all, and that's certainly something we're utilising in our hospital. Of course, there's always user error with anything, but in this quite larger study, there was only 2 elements of misread, whereby a more expert person had reviewed scans and actually said, I think this is probably representative of a small effusion, there's a convex capsule, etc. And that's just something that we do within our department when we're getting people competent from having done none at all. But what's brilliant is that POCUS can be repeated and is far more repeatable than that of repeating blood tests, for example, which is something that I feel fairly strongly about not being helpful kind of lots of the time. Someone has asked, what are the standards to compare size of effusion to? That's a really good question. So yeah, the bigger the child, the bigger the effusion. The biggest effusion we've ever seen is about 1.3 centimeters, which doesn't sound much, but looks absolutely enormous on the screen. What we're seeing here on the screen would probably be about 0.5, 0.6, 0.7 of a centimeter, but it's hard to say without knowing exactly the scale. And yeah, anything above 0.2 of a centimeter would be considered positive, obviously compared to the other side, and getting on for a centimeter would be massive. There's no age-related cutoffs because obviously it would be very relevant to each age of the child and the size of the hip and the size of the capsule. So a big 10-year-old, for example, might have a big 1 centimeter effusion that looks proportionally the same size as say a 0.3 centimeter effusion in a little toddler. Hopefully that makes sense. How many scans are needed to make you an expert enough to get those particular specificities and sensitivities? That's a good question as well. So I think the paper demonstrated that it's easily teachable. Now, I always start with this kind of scan with our fellows, and hopefully if any of them are on the call, they would testify that it's not really difficult to do in terms of getting the views. I'm just going to wait for someone to back me up in the chat there. But in terms of the physical identification, positioning of the probe, it's not really incredibly taxing. It's certainly not as tricky as, say, going in and undertaking an echo scan. There we go. One of my colleagues has backed me up. Wonderful. And that person's been scanning and these 2 people have been scanning for sort of around about a year and, got started. And this person as well, who got started with hips first. And there's a lot of a less technical kind of expertise required from that basis. So I think it's a really excellent starting point for people to start. Or not to baffle people with sort of physicsy words, the only thing to be aware of when you're scanning musculoskeletal tissue is that there's this thing called anisotropy, which is basically the interaction of the ultrasound beams with different layers and different fibers. Person who's got the hand up, I'll come to you in just one sec, thanks. And that it can mean that there's a bit of an angle dependent interrogation of the tissue. Now, all I mean with that is in order to get a reliable result, you basically, as per this, you've got to be fairly appreciative that on one angle with your probe, you might make the soft tissues and the muscular tissue, muscle in particular, and kind of fibers and connective tissue can look probably darker than in other planes. So all that means is that, as per the thing I showed you at the start, I always recommend people to show cine loops. So to just, a colleague, for example, might ask me about an appendicitis and send me a picture anonymized. And it's much, much easier to have it as a video, a cine loop, 3 or 5 seconds, rather than a single image, just because, nothing's perfect. And it's really, really hard to appreciate whether or not there is anechoic dark fluid in a joint space or whether or not it could be angle dependent. But as you've seen, hopefully from the cine loops at the start, it's fairly clear when you kind of get into that tissue plane and show it at the right angle. So I think, picture's worth 1,000 words. A cine loop is worth maybe 10,000. So that's what I'd say. Kaylee, did you want to ask your question?
Hi. So where I work, we follow the peer network, atraumatic limping child pathway, where we watch them in ED if they're afebrile. On the first attendance, we then send them home. If they're no longer, if they continue limping, they come back 48 hours later, and that's when we X-ray and do bloods and stuff. But from this, would you recommend doing it on their first presentation or on that review presentation?
That's a really good question. I guess, honestly, what I'm going to be going forward to tell you guys in time, which might blow your mind, but again, hopefully some of my colleagues on the call might back me up, is that we maybe don't need to follow some of these kids up, or in fact, we maybe, yeah, we definitely don't need to follow a lot of these kids up, is what I'd say. So that sounds mind-blowing, but it's important, I think, in your department to set up a system whereby everyone, you know, a parent, I must admit, they really, really love seeing the scans and feel really appreciated, but occasionally they'll return for follow-up and then expect to be scanned again, and it might not be one of my colleagues on the shop floor who does that. So I think it's important not to set up a sort of two-tier system that could lead to any problems. But this is really the next 10 slides is what I'm going to be talking about. How do we integrate this into decision making? How do we reliably diagnose transient synovitis that really probably doesn't massively need following up? I mean, at the start, it's excellent to get them back and to see them not limping, and then to look at your effusion size and to see that it's literally halved or disappeared. It's really one of the most satisfying things, because again, this is the next couple of slides. With transient synovitis, we've talked about this sort of mythical, magical thing that really parents, I don't think, genuinely get a good understanding of, having now shown them things on the screen and heard that. I think one of the best examples was one of my colleagues who I think might be on the call from our department had interacted with an anaesthetist, two anaesthetists and their daughter, and to get a doctor's perspective on kind of what he was showing them on the screen and the effusion, they'd wrote something like really lovely compliments into the trust, saying that it was amazing to be reassured by this, and that, you know, they'd been talked through it. So I never really liked the description of transient synovitis as being almost a rule, a kind of almost diagnosis of exclusion. But hopefully all of your questions, if they're of that nature, will be answered over maybe the next few slides. So, you know, not going to tell pediatricians in the room about transient synovitis. We know what it is. But this is the thing we don't want to miss, which has kind of significant implications and can present at all ages, from neonates, which is an age I've seen, right up to, you know, older children that make you feel a little bit uneasy. And obviously, you know, it can be variable in its approach, although of course most people have temperatures. It can catch a lot of people out. Wonderful. So someone else has stopped following up their limps. 2 weeks still limping. Yeah, great, good. This is what I'm going to be talking about, so that's good. And POCUS will really, really help back this decision up, let me tell you. So Perthes is really interesting. There are very, very, very few studies looking at the role of ultrasound or any kind of effusion on Perthes. I only found 2 from 1990 onwards. One of them was a German article. So what we've understood is that for the Perthes kids we've had who basically aren't improving on return or have had a slightly more unusual presentation, so those who are older or those who've had repeat attendances, some of them do have effusion. I would say it's a lot less than 50%. But it's something to bear in mind. But again, that's going to be integrated into clinical decision making based on age and how you feel, you know, whether or not this fits with a simple transient synovitis or not. So it'll be literally the next slide where we talk about our flow chart that we would use in our department. But we know obviously that children above a certain age obviously warrant an X-ray. I would say that's probably about 6. And that's just because we don't want to miss, you know, the really important bony changes such as Perthes. Osteomyelitis is a really, really interesting one as well. There's hardly any evidence out there about hip effusion in osteomyelitis. I'm sure we've all had a case we can think of each where sometimes they have had an MRI scan which revealed effusion, but I can think of lots and lots and lots over the past year whereby they really don't. So I think, again, it's a different kind of group in your mind that you're thinking about with osteomyelitis. You're thinking potentially about red flags and about children who don't fit nicely into our clinical decision rule, which, as I keep saying, I'm going to come on to in a little sec. But we've got the PIC bone study coming out, so that is exactly the process. That is exactly the objective of that study, isn't it? It's to a multi-center study looking into how MRI and ultrasound can help in potential bone and joint infections. So maybe that'll shed some further light. Yeah, and someone's just putting in the chat, one of my colleagues from our department, about kind of how we feel. And again, he's doing the work for me, so that's what I'm coming on to. But everyone's heard of COCUS criteria. So this was an original paper from 1999 from an orthopedic surgeon in Harvard. I think it was his thesis originally, where he looked at kids from the 70s up to the 90s, large numbers of people, and in essence sort of tried to distill down some rules which would be sort of red flag features. We now use ASR and CRP of over 20 interchangeably, I think. But again, any children who were more concerning in terms of active temperatures and not weight bearing, I think clearly we might scan them, and we might scan them and find a fusion, which is great. But clearly we're going to do the needful in these children. Now, what's really interesting is what happens if we see a child who is weight bearing, who isn't weight bearing and has temperatures, but we don't find a fusion. Now, again, I can tell you from like 4 to 5 years worth of this and 550 patients, I think me and my colleagues feel really happy that we wouldn't be concerned about septic arthritis. The best example I've had is recently when one of my colleagues, who's an orthopedic surgeon, asked me to come up to the ward to scan a child who did have these features, some of these features, and he said he wasn't too sure. He just didn't get a feel that it was definitely a septic hip. He asked me to come up because he'd been booked for theatre in the afternoon, and said that could I just at least scan him first, because he didn't want to rush him into theatre if he didn't have to. I went up, I scanned him, he had no hip effusions either side. I told him really clearly, I said it's not septic arthritis. He did have temperatures and he did have a bit of pain, but I said it's I promise I'm happy it's not septic arthritis. He didn't go to theatre, and he went and had an MRI, and he had a pyomyositis of one of the spinal muscles that was leading to his pain. And again, you know, it's not often you get either a thumb up from an orthopedic surgeon, but he'd said, you know, that's excellent, you saved that boy going to theatre. So that's the kind of reliability we've got in some of the cases, to be honest. So this is our limping child protocol. I know nobody can read it, but I just want to give an overview of how kind of relatively complex, and you know, I always found it complex without ever being massively helpful, to be honest, particularly for the average limp, which is transient synovitis, coming into your department, because it, as I said at the start, it treats it as a diagnosis of exclusion almost. It says, you know, if you think it's the site is clear and you think it is the hip, then it's bound to be transient synovitis, so just do this and follow them up. Well, what I'm going to come on to is reasons why probably POCUS is much better to at least integrate into that thinking. So people may have heard of this paper, which was a paper in Haifa in Israel in 2021, which was using POCUS, and it's at the moment the only one of its kind to use emergency perform POCUS as part of a clinical decision rule, or what they call a decision support algorithm for suspected transient synovitis. So they had quite a large number of patients, and it was anyone with what they described as pain originating from the hip, or hip tenderness is the word they used in the study. And in essence, what we had to have was these 5 clinical rules fulfilled. So not too young and not too old, to be afebrile, to be weight bearing still, to have a short duration of symptoms, and to look kind of well. So not to look pale or to have features that were concerning. And then they scanned the children, and they looked at how good POCUS was at identifying transient synovitis. Now, from a sensitivity point of view, it was really good. There's a few interesting caveats to their data, and that they had a slightly lower specificity and negative predictive value, because they had 6 patients in the study who were either scanned too early, 4 in this case, who were scanned and then scanned later, who didn't have an effusion within the first 24 hours. And again, I think that's 24 hours. I think you definitely start to see some symptoms, but it's very unclear, isn't it, with a 3-year-old exactly when their symptoms began. And I think that I would agree with that finding. But there was one case of Perthes, and there was one knee problem where someone had felt that there was a hip effusion, and the issue was found. Well, in the end, they felt that it was the knee. I always think it's really tricky because you can't be absolutely 100% certain if something gets better that it was or wasn't transient synovitis. That's the problem. The index test is just a child getting better. In this study, they looked at the child improving or reduction in effusion. And the reason I'm talking about this is because we are doing this same study in our department at the moment. We've just started looking at the data, and I'm going to talk about that. So this, for anyone who wants to look it up, was a really, really good was a really, really good paper and the first of its kind to just wrap around your brain about how we might integrate POCUS. So the reason I'm harping on to you guys about limping children and POCUS, and the reason why this was the first thing that I started scanning and the first which really set me on the journey to talking to you every month about POCUS, is because this is what happens in our department. We get a child who has this x-ray, then this x-ray, then this x-ray, then this x-ray, and none of them are helpful. And then one of my colleagues on the call come along and find that. And that is all we need to be doing. We don't need any of these x-rays because it's usually a 1-year-old child or a 2-year-old child, and there's clearly no trauma. And we can scan them dead quickly and dead easily, and we can repeat that scan. So the way I think about the role of POCUS for this is that if you have a child who's an undifferentiated limper, well, you can immediately confirm the site. You can confirm it as the hip and not the knee or anywhere else. And by non-hip causes, I mean that it can exclude very unusual, worrying things like the spine, the abdomen, the testes, the appendix, whatever you want to call it. It can narrow it down to 2 diagnoses, probably maximum, really. Fair enough. Osteomyelitis is an interesting one and can be indolent, but really you're talking about transient synovitis, septic arthritis. So what I mean by that is, if this child's limping and one of your colleagues thinks that he looks a bit unwell potentially, and you're a bit worried that he's either quiet or a bit pale or lethargic, well, if you scan his hip and you identify a hip effusion, that is not a child who has cancer. They do not have ALL, AML, they have a hip problem. And clinically, making that decision is really, really hard, and we would all want to depend on doing bloods and thinking about things, but using POCUS can immediately tell you that you've got a hip cause. And I'm going to show you an interesting slide next that hopefully makes that a bit clearer. But just to summarize how we might integrate it into your own department, actually, is that if you have a child who has a fusion and they're afebrile and they're still weight bearing, well, the data seems to be showing that in virtually every case, provided your scanning protocols are relatively tight and people feel competent doing them, is that the data would suggest, as much as any data for any condition does worldwide, there's nothing, this could be the talk on appendicitis, and there's nothing that is ever black or white, of course, but the data would suggest that that is a child with transient synovitis. So do we need to follow them up? Could we follow them up through telephone only, or could we just give them an information leaflet being very explicit about what we found? I know we already use that information leaflet, I'm sure your departments do, but what I mean by that is we can now definitively tell you that we've got this right, it's the hip, it's not septic arthritis unless we have fever and we're more concerned. But we can say with massive certainty now that we haven't got this wrong and we haven't missed something outside of the hip joint. And what do I mean by that? I mean this next slide. So for anyone, particularly who is from the EM side rather than the PEM side on the call, who might have the task of trying to clear a busy department at midnight and you've got 5 or 10 children still in your department, well, one of them might be a limp. And in this particular group, these are all the potential conditions that you might see. So I haven't brought in any of the hip or ankle causes or even most of the lower limb things. I've just thought around about the sort of typical limps, non-traumatic limps. These are all of the potential diagnoses that you could see in a 2-year-old who could come in, or a 5-year-old in the case, I guess, of Osgood Schlatters. The ones in yellow are examples in our department over the past few years where we have had an active role of POCUS and how it is positively confirmed or negatively excluded a diagnosis. So again, one of my colleagues on the call was involved with a child who was in our department for about 4 hours with a limp and some hip pain and some groin pain, and he was being managed as a potential unusual torted testis, and the urology team had been back and forth reviewing. There was no provision for testicular ultrasound in this particular case on that day, as is often the case for pediatric abdo scanning and testicle scanning. And he was being listed for theatre, and my colleague had a little look at him and scanned his hip, and he found a hip effusion, and he didn't go to theatre for his testis anymore. It was a hip pain. He was let's say a 7-year-old lad or a 5-year-old lad, I can't remember. And it really helped us to kind of use all of the tools available to us when we're making clinical decisions, and really for the good of the patient. And again, all of the other examples in yellow are some that we've had ourselves. A couple more questions. What do we mean by weight bearing? A lot of them will not fully weight bear after pain relief. Yes, that's a really good question. And I think it's about, probably in your own just non-POCUS clinical experience, you'll get a feel for the children who put a foot down and can probably reassure you by doing 1 or 2 steps and don't seem in an extreme amount of pain. And then perhaps anytime you do come across a septic joint, you might see that the difference is really significant. So yes, we would give them some pain relief and see if they did want to convince you that they can walk a little bit, and you might feel happier. But I think the children who really worry you, and I'm not talking about ultrasound here, I'm talking about the ones who are just of concern, is the pain is much more severe. At the septic hips that I've seen and the septic ankles, it's almost a fixed hip that doesn't want to move a lot of the time. So you've got things that you're integrating into your thoughts, aren't you? You're thinking, okay, is this a child who's particularly young? So under ones always are a bit of a worry, aren't they? A bit like my child at the start. And we might think, okay, he's only 10 months. I think out of 5 septic joints we've had, 2 of them or 3 of them were under 1. So that's really kind of something we would consider from the offset. But yes, you want to understand that the degree of weight bearing needs to be relatively reassuring for you for what you would expect for transient synovitis. And I guess you could have a low threshold for that if you were concerned. You would review anybody who you felt wasn't weight bearing again, and that's probably what I would do. Lots of questions for me to try and go through. Describing afebrile, febrile, and hip pathology does have to be documented temperature. That's a really good question, Reggie. So for us, our child, the bit that worried me was 2 things at the start. I don't know if you saw the case, if you're on the call at the start, hopefully you did. And that was a 1-year-old. So I was already thinking he's on the younger end of what I'm happy with for transient synovitis. And he'd had a history of described temperatures. I think it's important just to err on the side of caution, really. And if there's any doubt in your mind, just consider any temperature history of being a concern. Now that's more of a worry because you may well have a child who's had a viral upper respiratory tract infection at that point, who clearly has had temperatures as part of that. And I think again, just you might have to err on the side of caution if you do have concerns about any potential temperature. But just remember, septic arthritis is really rare. Honestly, I promise you, I scan every day. Sometimes, I don't scan every day. I'm going to tell you, you don't need to scan every day. You just scan when it's really important. Some days I'll scan every day, some days I won't. But I might scan 5 hips or 6 hips in a day and make a diagnosis of transient synovitis regularly. So septic arthritis you've just got to keep it in your mind that it's the kind of rare thing hiding in the background that's not going to be a daily presentation by any means. Question about how is process about convincing radiology. So yeah, that's a really good topic to talk about. I'll come back to that one at the end, actually, and a bit about governance. Yeah, I'll come back to that at the end. And someone said fantastic talk, so I'll send that person some money at the end. Thank you. You've did what was asked of you. Now I don't know who that person is, but thank you. Right, so just a bit of a summary, really. We're nearly at the end. Why do we use POCUS for limp? Well, the answer about POCUS for everything that we'll keep coming up against is that it's quick, it's easy, it's painless, it's reproducible, it's non-irradiating. But one of the bigger bits I would say is that the visual representation of a hip effusion or an elbow effusion or an appendicitis to the parent is so reassuring. It makes you feel like a proper doctor. It did for me anyway. I felt like I could cut through any uncertainty as a consultant and tell them exactly what I meant. And the feedback we get is to that effect, that they really, really do like it. Just going to plug the laptop in case we run out of battery, because that would be embarrassing, wouldn't it? And because limp is a really non-specific presentation, it is a really strange presentation that can mean lots and lots and lots and lots of different things. It can mean malignancy, and that is something I would not want to miss. And I think that blood tests, I'm always saying this in the department, but blood tests for so many things cannot get you out of jail. They really cannot. I mean, of course, you'd like to think that they're going to show us leukemia and lymphoma, of course, but I would hate to just decide something purely based on a blood test. And when we've got limp, we're very concerned about what it could mean. Putting a probe on a child's hip is medicine in its truest form. It is science in its truest form, and it can tell you what it can be and can't be. And yes, of course, there's a big learning curve about all of this that we're going to be talking about, but it's really, really important to use what is available to us, and POCUS is now definitely kind of part of that. To address point 2 on the slide here, studies have shown that it can be performed really, really well after tiny bits of focus training. I think kind of 2 1-hour sessions would probably be enough, to be honest. If you came to the department, we showed you how to do it. And then, of course, with limp, again, pain can be referred from places. So not only are the diagnoses really, really serious and concerning, like what we talked about, it can be literally from nothing to do with the hip or nothing to do with the lower limb. And then obviously some of these things can be time critical as well. So what happens if you did have a tortic testis? That would be, you know, you don't want to mess around too much waiting for bloods or waiting for radiology performed tests, when actually you as the person in charge can just do a hip scan and cut through things quite quickly. I'll get to your question in a second, Kat. So how do we do it now, department? Well, we go to the child who often looks in pain, and we tell them we've got a special machine, and do they like slime, and does your mum let you have slime? And the mums never let them have slime, so that's my good little icebreaker. And say, yeah, I didn't think you were, but we're going to use some today, and that this machine isn't scary. And we have these little soft models that we were given by GE to play with sometimes, that we give to the child, and warming the gel is really helpful sometimes. One output that we've had from this so far was that we had just a little tiny poster that we presented at APEM that showed that when POCUS people were around on the shop floor who were going to scan, we were able to reduce the number of investigations that was being performed. So in other words, in 1-year-olds, unnecessary x-rays, and in your average child who was afebrile and well, children were getting bloods done unnecessarily. Now, the answer I always give when I'm trying to, you know, explain some of the importance of POCUS is that if we try and make a decision with a blood test and the SHO has an attempt at bloods, and then the practitioner who's a bit more experienced has an attempt, and then it goes to the reg, and no one's been able to get these blood tests so far. Sometimes you can be on the 7th attempt and they're asking you to take these bloods. Now, I've gone into a room many a time, and it's a very well looking 1-year-old. It doesn't even have to be for limp, can be for another condition. It can be someone who's really not got appendicitis, they look fine. And rather than do those bloods again for the 8th time and probably land myself into a complaint, if I can't manage it, I'd rather just kind of try to use ultrasound where I can to help me make really, really solid decisions. So that's just kind of the way I am as a person. But I can assure you, so far we've not had any mishaps using this approach. Me and my sort of main group of colleagues who are doing this a lot. And then what next? So I think I'll come back to the questions in a sec. So I think we are looking at some data, basically applying the clinical decision rule from the Israeli paper, and we're nearly finished that at the moment, and we're going to see whether or not, one, is the clinical decision rule appropriate, and we've used patients aged 1, I think, to 9 and below, as opposed to, I think they did 2 years or 3 years. Is that an appropriate clinical decision rule? But what I'm really interested in seeing is, using POCUS, is the diagnosis of these conditions more accurate? So in other words, comparing it to just clinical examination alone, do we get it wrong fewer times than compared to that of just clinical examination alone? Because remember, your scan is just an extension of your clinical examination. If you've got a child with a sore hip who doesn't want to move the hip, rather than upset them and go straight in and try to move things around, I would rather utilize POCUS to do that, because it can give me a lot of information, and I might still examine them in a certain way. For a hip, honestly, I probably don't nowadays, but there's other things we can add in that can help things. So I'd like to see whether or not POCUS can really play a role at making it more accurate. And so far with our data, we've had 185 cases of transient synovitis over 5 years, so about 2 a week, 1.8 a week, which sounds about right. And we've not had any, so far looking at the data, applying our clinical decision rule plus POCUS, we've not missed anything as of yet, and we're nearly finished looking at it. We've not missed any septic arthritises. There have been a couple of cases whereby the early scans have been done and they haven't shown effusion, which is definitely something to keep in mind, but that's nothing you can't get round by following the patient up. And then just to finish, I always put this slide at the end of any talk I give, which is just, you can read it all for yourselves, but you know, it means your patients and their families will like you more if you do ultrasound. Right, questions. Malignant effusions, yeah, that's a really good question. TB effusions, any joint can have an effusion at any time, and I would like to think you'd always pick up children who either look more unwell, who have chronic features, who have fever, etc., etc. So remember, we're talking typically about a tiny group of, a massive number of kids, but a really specific remit of children who are very well looking, who can still walk around, and almost certainly from the data are likely to have transient synovitis. And if you didn't see hip effusion, remember, you then move on to a different diagnosis. So it's not just about ruling out as it is ruling in as well. So it has other rules. Of course, things can always catch you out as rare findings, but I think it's less that you'll see an effusion and it's likely to be a rare condition. I think it's more likely that you can reassuringly rule out a rare condition by finding a hip effusion. So in other words, if the question's about, you know, could it be this? Well, actually, you can distill it down to just a few tiny diagnoses. But yeah, maybe that's the next thing for us to look at. And then another question, just to emphasize, you've also alluded to and specified in your talk the importance of detailed history and chronology as an adjunct. For example, to ensure effusion is not the result of infiltration for a malignancy. Okay, so yeah, I mean, I'm not too sure specifically what that question relates to in terms of effusion, but the pain from hips with you know, non-solid tumors relates to marrow hyperplasia and infiltration there, and that's kind of why children limp with leukemia. So those children don't have effusion. But of course, yeah, you could have a bony tumor that's causing some problem. I think, again, all of that with your initial kind of application of a clinical decision rule, but also your follow-up is likely to absolutely help us decide what's going on with those children. So again, they would not fall in the category of a likely transient synovitis. Those would be the ones who we would continue to review, or we would find that they've got no hip pathology at all, and we'd cast the net a little bit wider. And then there's a question about, or point, can definitely see the value in this, but the child who meets the inclusion criteria for POCUS less than 7 days well, and here you get clear clinical signs of a joint effusion. Does the scan add anything specific? We'll put in the programs.
Where is the house sprung?
Okay.
Oh, they got.
Someone's asking, will putting the probe on seeing effusion or not change how you manage that subset of patients? 100%, because the child who's got 1 day history of limp, who's afebrile and still quite well, has had testicular torsion as well, and has had appendicitis, and has had lots of things going on. So it's limp. So we think it's definitely hip problem, but I think we need to identify that it's a rule-in diagnosis of seeing that there is a hip effusion there. And I think we've had that lots and lots in our department ourselves. And then someone's sharing something about our course, which is great. Thank you for that. Yeah, so that's slides-wise, that's all I had to talk to you guys about. Trying not to get too kind of enthused or evangelical about hip scanning, but I think it's really one of the areas that has been excellent for us in terms of just really clarifying things and making decision making a lot easier. So I think it's one of the ones that is easily teachable and something you can integrate into your own clinical practice. And I hope going forward that people would like to give that a go. Are there any other questions at all? Oh yeah, thank you. Sorry, Jackie, thank you. Yeah, question about governance. And no problem for people who've got to go. Thank you so much. We're nearly on the hour. So we've had a really interesting journey in our department. It's almost a different talk. I'm doing a talk at RChem next month that they've asked me to kind of talk about more about the journey, and it's been a really interesting one. So I think we've linked in during our postgraduate studies with a lot of radiologists and radiographers who teach on the course. And so it's nice having a familiar face and someone who you know very well. But I can honestly say that even regional radiologists at the tertiary centres kind of across the way have been brilliant about POCUS in our department. I think it's because we've tried to tackle this in an extremely governance heavy sort of way. We set up our group and we got together and we had the clinical governance lead as part of that. We had representation from adults and from juniors and from adult ED, as well as from acute medicine, and everyone just brought a little bit of something to the group, whereby we tried to define exactly how we would be, using each individual scans. We wrote guidelines which were peer-reviewed and evidence-based. So we've got about 13 evidence-based kind of guidelines now that have been ratified through clinical governance, and we have basically tried to, Niall's just iterating this talk in relation to your question, Jackie. I think what I've tried to do is to not cause any trouble for any radiologists around the corner from IED. And what I mean by that is I don't think that I've scanned anything and got myself into a spin and asked them to do unnecessary things. I think equally we're so cautious about not undercalling things. So when we began scanning them in the PEDS emergency department, Dr. Mullen and I did a lot of non-contributory scanning where we really sort of defined like what it is we were looking for and how we would do things and what the specific protocols were. We then linked in with my colleagues overseas, how they do it, and you read as much evidence as you can on the topic about how you can scan as best as possible, and then how we will use it. So we were doing non-contributory scanning. We weren't discharging children and saying that's the end of it. We were literally doing a scan and almost not counting it at the start as part of our clinical decision making. But then you become really skilled at doing it, because you're scanning at sometimes maybe 5 hips in a day, or you can scan 10 if you go and do a scanning shift where you just scan every well patient who's come in with a head bump. And you realize that it's kind of very, very binary for things like musculoskeletal things. So we do an awful lot on pulled elbow and elbow injuries, upper limb injuries. And then you just build upon it. So whenever we've then needed radiology input, I think we've just tried to work alongside them, asking them really specific, well-defined questions. So the common one at the moment, Jackie, would be appendicitis, which is probably my favorite thing to do at the moment. But we've been doing it for around about a year now, and we're doing another study looking into this, and we've got I think 41 cases that we've scanned since January, and that's only when myself and Dr. Mullen are on the shop floor. And the way he described it to me, Dr. Mullen, is he said that we're almost shifting the expertise of day-to-day appendicitis scanning away from the radiologists, who don't often like to get involved with anything, and probably get a lot of unnecessary scans done from the ward for puzzling children who probably aren't appendicitis because they've sat on the ward for 4 or 5 days and they turn out to be something else. So we're trying to, again, kind of looked at do that in a very, very governance heavy way. We've got a guideline for that, but I think it's about taking really small steps, of which hip scanning is one of them, linking in with a familiar face who can support where needed. But I've honestly kept it in my mind about trying not to create work for anybody and not to bother them with things. I think one of the radiologists is the sister of one of our EM consultants, and she told him that I was intelligent, so that I'm glad with that. So I think I've just tried to go around with some really to not bother her with silly things and to ask specific questions. And I think often when I ask her to do an abdo scan or a pelvic scan, we nearly we found something sort of every time, funny things like hematoculpus or unusual bits of free fluid. So I've tried to maintain credibility, and I think with the correct training and like you just really giving POCUS you all to improve your scanning technique and all of that stuff. I'm sure I've met you before and we've done scanning and things, so I'm sure your technique's brilliant. But I think you can kind of guard against a lot of the challenges, what people ask us about, which is the governance side of things. Does that, in a really roundabout way, answer your question, Jackie? I hope it does.
Yeah, thanks so much, Dave.
Thank you. If anyone else has any questions about HIP or about anything else, I'm happy to answer them. If not, I'll just say before people have to shoot off, it's been amazing to get so many people on the call. I'm utterly blown away by the fact that 130 something people are on the call, like blown away, and we've had 450 people sign up for it, so that's amazing. Just get in touch with us via email as to whether or not you think you'd like to keep this a monthly, which is probably what we'll do for the next month, but we might want to then do it more frequently. Typically, I guess we'll do stuff like cases where it's much more interesting rather than what I think is an entry-level talk today. You know, a bit more of a how-to, but I think this was probably a good starting point for that. So hopefully some interesting stuff to follow. And thanks so much to Nigel, who's been helping out. He sent all the emails around and did all of the Google form, which I couldn't have done. And thanks for your interest, guys. Have a good rest of the day. Any final more questions before we finish? Okay, thanks, guys.